Great. So are you happy for me to just get going?
Yes, welcome
Yeah.
to this week's TMB meeting. We have David Herdman. David, take it from here.
Well, thank you very much. Yes. So, yeah, I'm David Herdman. So my background is as a clinical academic physiotherapist in vestibular rehabilitation, and did my PhD actually in health psychology, and have now joined the lab with here at UCL with Diego Kasky, who you will be hearing from. And you'll also be hearing from Toby Elmers and Will Sedley as well. So this is kind of the well, firstly, thank you for the invitation to come and speak to your distinguished group and to get feedback. It's really, really helpful. But this is kind of the result of some of the conversations and meetings that we've been having as a group in terms of developing a model of persistent postural perceptual dizziness. So I'm going to set off really with the easy bit, which is kind of to describe, for those of you not familiar with vestibular medicine and triple PD, actually what it is and why we're interested in it. So actually triple PD is a really common cause of chronic dizziness. So it accounts for kind of 1 in 5 patients that come through neurotology services, and it can cause some very distressing symptoms for people. So one of the sort of core symptoms that patients describe is a vague sensation of unsteadiness, just this feeling of constantly rocking on a boat or almost like walking on clouds. It's just this kind of vague, non-spinning type of illusion of movement of themselves, which is obviously chronic and persisting in nature. And it tends to be exacerbated by 3 main things, which is one being upright. It's worse with any kind of active or passive movement, and also exposure to moving visual stimuli. So movement of their own body and that of the world around them seems to exacerbate the symptoms. It can actually be precipitated by any condition that causes vertigo or unsteadiness or any type of dizziness or problems with balance. So actually triple PD can arise not only after a kind of vestibular insult, but also after other causes such as like panic attacks or falls or things like that nature. They cause significant distress or functional impairment, but this itself is not a kind of psychiatric disorder. Rather, we would term it as a chronic functional vestibular disorder, in that sort of sense that how neurology use the term functional to mean a change in the functioning as opposed to kind of structural damage per se. So as I say, kind of it can be triggered by a number of different events, although sort of a quarter of the episodes are triggered by a vestibular insult, say a vestibular neuritis or an infection of the inner ear, from episodic conditions like migraine and other episodic vestibular conditions like Meniere's disease. But what happens is that, so say if the initial trigger was something like a vestibular neuritis, you'd have a sudden onset of very severe acute vertigo or imbalance, and as that was settling down, then this more persistent course of symptoms would then emerge, as opposed to say something like migraine or another episodic condition where the patient might experience initially in the early phase of their disease episodes of or distinct kind of attacks of vertigo or imbalance, but as the disease progresses or becomes more frequent in nature, then these more constant chronic underlying symptoms start to emerge. And this is just to show really what happens with an acute vestibular event. And this is actually Karlberg and Magnusson in Sweden, who actually injected themselves with lidocaine in their inner ears to essentially simulate what it would be like to lose one's vestibular system. And you can see here that as he tries to get out of bed, he's acutely off balance and disoriented. And he's really sort of not trying to restrict his movements, holding his head very firmly without moving. He has a wide base of support. And this is actually the kind of typical or a more severe version of the gait pattern that often persists in people with triple PD. They develop this highly cautious approach to gait and balance. And actually, this is why I think in the literature, trait anxiety is not a very strong feature in triple PD, because actually anyone can develop it. And if you look at the studies that have examined anxiety levels in the first attack of vertigo, unsurprisingly, these are a group of people that are acutely anxious, as it is quite an alarming experience if you've ever had it. So what are the factors that are associated with recovery from vestibular neuritis? Well, actually, if you look at the evidence, almost all the evidence suggests that the type of parameters that we might use in the laboratory to measure vestibular system functioning, like calorics or other types of vestibular function tests, actually hold very little weight in terms of their predictive value, in terms of whether someone will or will not experience more persisting symptoms. Instead, actually, psychological variables seem to stand up much more. So, like for example, in this study, showing that symptoms of anxiety or depression, or how much patients attended to their bodily symptoms, seem to have stronger predictive value. The other thing that this study shows is visual dependence as being quite a strong predictor of persisting symptoms. You'll see in the image there that essentially one of the ways that we test visual dependence is asking patients to align on a computer a line up to where they perceive the vertical to be. And then we apply a rotating background. And so essentially, then it's measured whether they can still align that to vertical, or how far off, essentially how much their sense of verticality is displaced by the moving visual stimuli, or whether they can effectively tune out that visual stimuli and still align themselves to vertical. So the extent to which patients are dependent on vision seems to have some predictive value in terms of recovery or not. And again, this is just from a Belgian group that, again, showing kind of similar results, that actually the amount of avoidance behaviors that patients were doing at 10 weeks after vestibular neuritis, and the amount of kind of visually induced symptoms that they were getting, seemed to be the two main predictors as to whether patients would experience more chronic dizziness, or whether they would kind of symptomatically recover. And so actually, if you look at the kind of, this is a nice systematic review, you can see across the studies, in terms of different precipitating events or vestibular events, actually quite a large degree of variability in terms of the percentage of patients that recover or experience more chronic symptoms. But rather than, about a quarter of the patients across those studies do go on to experience persistent symptoms. And actually, it seems to be that early anxiety, the autonomic arousal and visual dependence that predicts the development of triple PD following a vestibular event, rather than the severity of the vestibular event itself. We also propose that actually triple PD has many similarities with another so-called functional vestibular disorder, which is termed Maladaptive syndrome. What happens with Maladaptive syndrome is that patients describe this oscillatory perception, so this ongoing experience of rocking or bobbing or swaying, that if you've spent a long time on a boat, or if you've gone diving and spent a day out at sea on a rocky sort of seas, and then come back on land, it's a sensation that you're still rocking. Yeah, and you may have experienced that yourself. But and this is just the photo on the right. There is a group of people in Indonesia that actually, back in the day, would spend their whole lives out at sea, and would report terrible land sickness whenever they came back on land. But obviously in this country, it's more likely that patients experience this after disembarking from a cruise ship or that type of thing. One of the key differentials between MDDS and triple PD, one is the sort of triggering event, so whether that's come on after exposure to travel, but also that in MDDS, symptoms temporarily reduce with exposure to passive motion. But actually what we experience clinically is actually there's a great deal of overlap there, and some patients with triple PD also report that sometimes their symptoms are better when they're in motion in a car or something like that. So there seems to be this sort of overlap between MDDS and triple PD in that way. And so actually, if we look at some of the models, I'll present to you now some of the models of triple PD. And this is probably the most sort of accurate or most accepted model of triple PD that, as I said before, it's sort of triggered by any condition that causes vestibular symptoms or disrupts balance. But what they actually share, those conditions, is that they represent a threat to postural stability. So they sort of induce this shift that includes kind of heightened sensitivity to motion and high-risk postural control strategies and this preference for visual cues. But normally they would return to normal as that triggering event resolves or remits. So in the majority of the cases, people will just return to normal. But in some cases, and as this model hypothesizes, in the context of excessive bodily vigilance or tension or maladaptive interpretation, it becomes chronic. And so the patients kind of shift their priority from fluid locomotion to one of stabilization of that sort of perceived excessive postural sway. And so they enter into this kind of vicious cycle, as shown around that kind of silhouetted image, where attention to postural stability dominates over a kind of natural focus on spatial orientation and locomotion through the kind of wider world. And then the attempts to kind of over control posture and gaze, and rely more and more heavily on visual inputs for balance. Again, kind of triple PD has been encapsulated as a subtype of FND, and this was Mark Hallett's paper in the Lancet, where they sort of mention kind of active inference or put it within an active inference framework, but where they're sort of explaining that there's this mismatch between kind of planning and preparation of movement, or when there is a mismatch, I should say, between kind of planning and preparation of movement, the feedback from either interoceptive or external signals after an action, then that movement won't be appreciated as voluntary. And in FND, it's kind of hypothesized that one of the hypotheses is that it's the prediction error that's then not accurately updated, and it's that then perpetuates the dysfunction. And I think when we were looking at these kind of models, the feeling is that we could go a little bit deeper within an active inference framework to draw that part of these models out a little bit more, to give us a little bit more insight into this kind of disorder. The other main criticisms that I had from my background as also as a physiotherapist, but also then in health psychology, was the lack of sort of this cognitive aspect, which we think is actually really, really important, rather than kind of this classically conditioned response to a stimuli. And if we look at the CBT model of triple PD, one of the key features in both its initiating and perpetuating phase is this threat appraisal. So the appraisal of illness, beliefs, and threat. And this kind of corresponds with my own previous work that showed that actually when we did a number of questionnaire studies in people with persistent dizziness, actually they're not unsurprisingly, their dizziness outcomes were not correlated with clinical tests of vestibular deficits, but rather the psychological variables, particularly around distress and illness perception. So how someone perceives their illness in terms of chronicity or causation, for example, as well as their cognitive and behavioural responses to symptoms, actually explain a very high amount of the variance within dizziness-related disability. So this is the type of typical model that we present within health psychology, that once we have a physical symptom and we attend to it, we are motivated to find a label for that symptom. And once we have a label, then again, that increases our focus towards physical symptoms. And it's actually our cognitive and emotional interpretation of that that then guides our behaviors. Two of the key behaviors that we think are relevant, especially kind of avoidance or resting, as being particularly detrimental to vestibular compensation, which requires active movement and exposure for vestibular compensation to occur. And also this kind of all or nothing approach, where patients kind of push themselves, but then the consequence is that then they sort of rest up for longer periods of time. And again, in this sort of smaller case control study of people after a vestibular event. It's the negative illness perception, so whether they perceive their understanding of their illness and whether they perceive their illness as negative in the form that it's likely to be chronic and cause serious harm. May be actually the key element driving that development of triple PD, where of course these sort of metacognitive aspects lie within a active inference framework is obviously one of the questions that we could consider today. One of the kind of potential biomarkers that have been investigated recently is that it is the difference between someone's actual and perceived bodily sway. So as I said before, one of the key symptoms of triple PD is this kind of vague subjective feeling of unsteadiness. And when you put these patients onto a force plate, actually they sway very little. In actual fact, almost less than a healthy control as they're attempting to sort of stabilize themselves, so they become quite rigid. But when you ask them to replicate the degree of sway that they felt that they were doing in their head, you'll see that actually they feel like they're swaying a lot more than they actually are. And when you compare that to people with, for example, on the right of the screen, that's people with bilateral vestibular loss, so kind of a complete loss of vestibular function. They do sway, but their perception of that sway is fairly well matched to the actual sway. So it's actually the people with triple PD that overestimate that amount of sway that's going on. And then this kind of brings us to this concept of postural threat, which I won't talk about too much because Toby will be covering this, but you can do funny experiments like this about putting people up on heights and things like that. And as I said, it's the people with triple PD often display this kind of motor action or balance related behavior that's very similar to how a healthy individual might approach standing 10 meters high in the air. They stiffen up, they take shorter steps, they fixate their eyes on the ground. So it's this kind of high threat postural control strategy that then persists unnecessarily. And so what are the ways that we have to treat this? Well, in actual fact, there's not really very much in terms of treatment that is available. One of the things is vestibular physiotherapy, but we tend to find that the traditional forms of physiotherapy that we would apply to a kind of vestibular disorder don't tend to work very favorably for triple PD, partly I think because the kind of exercises that we would give someone with a vestibular loss might actually get them to be testing their, training their vestibular reflexes or even attending more to their balance. And obviously anything that's going to increase attention towards balance in triple PD is probably going to make the condition worse. Likewise, cognitive behavioural therapy, but again, there's very many different types of CBT that's available, and that's not always acceptable to patients. And then medication is also an option, and some smaller trials have found benefit from SSRI, SNRI medication, but in our country it's less it's less prescribed for this condition, and there's been no placebo kind of controlled trials, and I think our own experience of SSRI for this disorder is quite variable, and patients often don't tolerate side effects anyway. So this was one of the ways that we are now currently approaching this problem of triple PD, is this concept of cognitive physical therapy. So this was part of my PhD, and it's now part of my postdoctoral fellowship, that actually, to be truly effective, the treatments that we deliver must be empirically derived and precisely targeted. So one of the things that we do is to start with a formulation, an individual formulation, so that the patients understand what may be causing or contributing to that kind of vicious cycle. Balance retraining in a very different way to normal kind of physiotherapy by using distraction and trying to elicit more automatic movement, and changing that kind of thing. But also one of the key things that we found to be most beneficial is in vivo exposure, where we're very deliberately trying to change people's predictions about the consequences of their actions or movements in feared or threatening environments. So, for example, if a patient fears going into a supermarket because, that might make them feel acutely dizzy and fall, we would actually practice going into that supermarket with them. So that's one of the approaches that we're taking. But obviously, if we can try to place triple PD and our treatments for that within an active inference framework and some potential mechanisms, then that might elicit better and more precisely targeted treatments. And at this point, I will hand over to Diego to talk us through some of the evidence around kind of the neuroimaging aspects of triple PD.
Thank you, David. So I've got the slightly more hand-wavy bit of the talk to give. I think there's probably little doubt that 3PD is a neuropsychological disorder, and so it sort of makes sense if you're trying to understand the neural underpinnings, that you'd focus on the brain, and that therefore you might do some brain imaging in these patients. And I think that most of the work that's been done, understandably, again, is been with functional MRI, in the knowledge that these individuals probably have some abnormal interaction between different cortical and subcortical brain areas. There are, maybe 10 or so papers that have explored brain imaging. 2 or 3 that have looked at structural imaging, which I'll touch in a second, but the majority has been either resting state fMRI or usually with the task associated with the imaging. So many of the tasks are either visual tasks that try and generate and exacerbate this visually induced dizziness symptom, things like fairground rides, sort of with virtual reality, or more simplistic tasks like using sound stimuli to evoke vestibular responses. And overall, I think it's fair to say that there are changes, functional changes that occur that seem to be consistent across studies. The majority of these tend to be an underactivation of areas that are thought to process vestibular information and are involved in the integration of our senses, including vestibular, visual, and somatosensory. So areas like the posterior insula. And there seems to be an increased activation of visual areas that fits with this concept of visually induced dizziness. And what's interesting is that people have often found that a lot of the limbic areas are also involved and have a dysfunction in terms of their connectivity. So there's a suggestion that there is some neural underpinning to the symptoms that patients manifest. It sort of makes sense from clinical experience. What's less clear-cut is to what extent these changes are the consequence of the condition itself rather than the cause of them. And that's really a big problem with neuroimaging of this kind, because, of course, if you've got a perceptual disorder like 3PD, you are going to change the way that you behave and the way that you respond to stimuli. And therefore, it may be that all of these changes that we're observing are simply the consequence of the symptoms themselves. A lot of the studies have been done with healthy control groups, but none of them have included a disease control group. So again, we don't really know how specific these changes that occur are. Could they be happening in patients with migraine, for example, and not just 3PD? So there's a suggestion that there is an influence between how the brain is operating in patients with 3PD, but less clear what the actual mechanism of that disturbance is. And then so we come to the sort of structural element of imaging. I don't really understand how there can be macrostructural changes in a brain of a patient with 3PD, particularly in the early phases of a condition, a few months into it, that it would alter so substantially. Again, I'm not an imaging person, so I don't know whether this is sort of statistical, really. Why you might expect to see some changes in the brain is what statistical parameters you use to identify changes. There's a whole range of abnormalities that have been found in structural brain scans in these patients, involving areas like the superior temporal gyrus, bilateral middle temporal gyrus, temporal visual areas of MT and V5 that are implicated in visual motion perception, but also areas like the cerebellum, precentral gyrus, anterior cingular gyrus, all these sort of areas that seem to have abnormal structure. So I am still very speculative, really, about whether one can really say that the brain of a patient with 3PD is structurally different to the brain of someone that doesn't have it. And I think, again, one of the major limitations of this sort of imaging is that the lack of a disease control group. No one has really compared 3PD to other chronic disease. So I think there are a lot of question marks really about where exactly changes are occurring in patients with 3PD, to what extent these changes are the consequence or cause of the symptoms that they have. And I think we need better studies really that integrate imaging together with perception, which is ultimately the core symptom or core problem in 3PD, and then behavior, which is the consequence of this perceptual disorder. Thank you. I'm going to pass over to Toby, who's going to talk a bit more science and sense.
Thanks, Diego. So I'm just going to talk for a few minutes about perception and some of the psychological factors that might influence this, namely attention, before we pass over to Will, who's then going to present kind of an early draft of our actual model. So as David and Diego have mentioned, a key symptom in 3PD is this chronic subjective instability. So patients feel more unstable than they actually are. So we were interested in these series of experiments in trying to induce the same distorted perception of instability in healthy controls. And we did this by raising them up at height, so inducing this postural threat and making them anxious about their balance. So what you can see in this group of healthy people, when you raise them up at height on the left, there's no real change in their actual stability. So they're not swaying around any more than they were at ground. If anything, they're actually swaying slightly less. But on the right, you can see there is this marked decrease in their perceived self-reported instability. So they feel far more unstable than they actually are when you raise them up at height. There's this clear kind of mismatch in perceived and actual stability, which is a core symptom of 3PD. And we can induce this in healthy controls by inducing this postural threat and making them anxious about losing their balance. So then the next thing we wanted to try to answer is what mechanisms might actually be driving this. And one of the key things that happen when you actually induce this postural threat is that people become hypervigilant. So they direct conscious attention internally towards consciously monitoring and consciously controlling their balance. So we wanted to try and see if this was a core mechanism driving these distorted perceptions of instability that occur during threat. So here, once again, we raise people up at height. So we had the baseline and the threat condition, and as with the previous slide, you can see the same thing. At threat, people sway slightly less, so if anything, they're more stable, but they report this marked reduction in perceived stability, so that once again, there's this distortion. We then had this additional condition, which we called threat plus distraction. So we gave people this cognitively distracting dual task, which were just naming the months of the year continuously. And this was designed to try to prevent them from being able to actually direct attention internally towards monitoring their balance. So then what you can see when you give people this cognitive dual task is, whoops, okay. So you can see that once again, there's no actual change in actual stability, but there is then this sort of attenuation of these distorted perceptions of stability. So they don't return to baseline. They're sort of in between the threat and the baseline level. So this to us was quite nice or strong evidence that this attentional kind of changes that occur when people are threatened might be driving, to some degree at least, these distorted perception of instability that is a key symptom of 3PD. Next, we wanted to actually try to see what then attention is doing to the cortical processing of this self-motion related input. So here, this is just some pilot data. We've actually collected now 20-something participants, but we haven't yet analysed this. So I'm just presenting data for the first half of the cohort. So here we sit people in this chair that rotates at slow speeds. It's a vibrationless chair, so you don't really get proprioception. It's in the pitch black, so you don't get visual cues, and there's noise cancelling headphones, so there's no auditory cues. So it's a pretty pure vestibular stimulation. And here participants received very slow rotations at about threshold level under two conditions. First was just passive, so they were told to just sit quietly. Essentially, their only instructions were just do not fall asleep. And then we had a vigilant condition. Here, participants were told to focus closely on each rotation. And after each rotation, they were asked to tell us if they felt the rotation. There were some catch trials. And then if they did feel the rotation, whether or not it was to the left or to the right. And throughout, we measured EEG. So firstly, just some manipulation checks. Well, you can see that the vigilant condition did indeed make people more attentive towards self-motion. And interestingly, participants reported, that's not the interesting one, this is the interesting one. Interestingly, participants reported actually experiencing the rotations as more intense during the vigilant condition, even though the actual stimuli was identical between the conditions. So once again, this does show that attention, kind of this hypervigilance, can modulate our perception of stimuli. And I think the really interesting results is the EEG. So we know that parietal kind of cortex alpha suppression is a hallmark of actually cortically processing the peripheral vestibular input. This is basically absent if people don't have any peripheral vestibular function. And what you see during the vigilant condition, as expected, there is this parietal cortex alpha suppression. But then during these passive rotations, you can see this is absent essentially. So once again, showing us that not only can attention modulate perception, but it seems to actually also directly modulate the cortical processing of this kind of peripheral self-motion vestibular input as well. And yep, okay, these final slides aren't there, but that's essentially what I was saying. So I think now we're going to pass over to Will to present some of the model.
Thanks very much, everyone. Nice scene setting, thank you. I'll just share my screen in while I'm sharing this. I think I was meant to do an introduction, so I'm Will Sedley, a Wellcome Trust Research Fellow. I've got interests more in established in auditory and tinnitus. I'm a bit of a newcomer to vestibular and 3PD, but do see it as a clinical neurologist. And this has been a nice process of trying to get to grips with the condition from the inside out, I suppose. So I think just to rehearse some core principles that we want to construct a model on that encompasses all the elements and observations we've just heard about. One thing that I think is really central to the account we've reached is that active inference systems should optimize themselves to their operating environment, with the appropriate trade-offs between complexity and accuracy, minimizing error, and all the usual free energy things, such that they roughly constitute a negative feedback cycle on free energy. And the thought here is that this shouldn't be different in what I'm not sure if this is the best term to use, but a vestibular proprioceptive motor system, the sort of system we're talking about here, that naturally integrates these inputs, motor actions, and minimizes free energy, optimizing action, etc. The idea is that if left to its own devices, the kind of core canonical part of this system should get it right and become roughly as good as it can be based on its own physical integrity, the quality of sensory organs, the operating environment. And so the optimization would include getting optimized priors, optimized precision of those priors of motion, particularly self-motion, optimal precision of prediction errors, an optimal degree of sensory attenuation. And what we're really arguing is that actually the simplest terms in which we can express 3PD is that it is something that interferes with the failure of the system's otherwise natural tendency to self-optimize. And that specifically during the necessary conditions, which is most strongly pronounced during ambulation, posture, self-motion, but not exclusively, that the core consequence of this leading to the symptoms is increased precision-weighted prediction errors compared to the optimal level of precision-weighted prediction errors representing motion in the vestibular cortex. And then there may be a few mediators of this, and then we'll come on to a kind of graphical representation of a model of how everything pieces together. But the reason, just as an intermediate layer to this, for why there could be increased PWPEs, it could be that the predictions, self-motion predictions, are inaccurate. It could with normal or high precision. It could be that they're perfectly accurate, but they carry low precision because they're insufficiently trusted. There could be increased attention to vestibular prediction errors, which amounts to increased postsynaptic gain or precision afforded to them. And then quite related to that, there could be the lack of sensory attenuation from motor actions, which is again permitting a higher precision on these prediction errors than there would otherwise be. So, but there are quite a number of moving parts to this. And I think the simplest number we can get it down to kind of feedback loops that interfere with the self-optimization would be four. They're four different elements. They don't have to apply in every case, but I think we felt like we would be oversimplifying and missing key detail not to include all of these. And so what each of these four elements have in common before I introduce them is they should interfere with this otherwise inherent self-optimization. They should themselves, so the system left to its own devices should have a negative feedback loop of energy and self-stabilization, but any of these elements that interferes can become self-reinforcing with a positive feedback loop that then keeps that otherwise process that should be optimizing itself away from its negative feedback loop. They should all contribute to this common result of excessive vestibular precision-weighted prediction errors. May not be present in each case, and to be useful, these should align with clinically observable symptoms and signs, present a particular therapeutic avenue, and have the potential to be demonstrated either at all for their existence, or even better, in individual cases, to quantify and objectify the sort of heterogeneity of different cases. So those four parts are, starting with, I suppose, the most established in 3PD, excessive attention or balanced vigilance, which constitutes a higher precision on vestibular prediction errors. There's then, as David said, the part that's often missing, metacognitive beliefs about imbalance that then feed down into our inference processes. Maladaptive motor behaviors, as we've seen a lot of evidence for, and this over-reliance on visual input. And just to say, our model should be equally applicable with or without this optional precipitating event or illness that we've heard is sometimes there, but doesn't have to be. So just to reiterate and graphically show this core of the model. Now, the specific anatomical structures are very speculative, as Diego has shown. The quality of evidence showing exactly which centers are involved is far from clear at all. So it's more we've got some putative ones like supplementary motor area as a generator or origin of self-motion priors. We can maybe be a little more confident that the next level down might be in vestibular cortex and posterior insular regions. But the idea is that you've got this situation where these two are hindered from working in harmony, that there's a high level of precision-weighted prediction error in vestibular cortex that feeds in, will be relayed to SMA in areas producing self-motion priors, but that fails to appropriately update and restore the accuracy or precision of these so that this state is perpetuated rather than temporary. I think we've kind of said all this. So we could, and that could be that this prior is of low precision. So there could just, that generally every sort of likelihood representation will be associated with a moderately increased level of surprise, or if these priors are actually inaccurate, then some likelihoods could lead to a very high degree of surprise. And erroneous priors could be a prior of a sort of an excessively firmly held prior of no motion, because motion can't be allowed, or a sort of catastrophic belief that unintended motion will occur no matter how you try to stop it. And this notion of sort of overly firmly held, excessively precise, erroneous priors could be quite a useful bridge with functional neurological disorder, where that's kind of the key part of it, as per the Edwards model from 2012 onwards. So this first element, this first sort of positive feedback loop that prevents stabilization, might be, for instance, mediated by the basal forebrain cholinergic system that is a modulator of attention and precision, and it could be it's easy to see how it falls into a feedback loop. It amplifies the precision of errors. The excessive errors keep triggering further vigilance and a self-reinforcing cycle emerges. And this would align with this sort of hypervigilance, hyper-anxiety, overly focused attention state, which is, I think, widely thought to be involved. So the next one, looking at metacognitive beliefs, is if these provide a sort of bridge between the important psychological traits and also a number of wider current factors about the external environment and the safety of that, the integrity of the body and internal environment, safety of that and everything. And so all appraisals of threat and things could potentially come through here, although they do affect attention as well. And then the idea being that actually, if you've got metacognitive beliefs that are different to what would ordinarily be your just unbiased, impartial self-motion priors, these could erroneously constrain, limit the precision of your self-motion priors if they're not trusted, or indeed even lead to erroneous priors. The priors could involve sort of predicting that you're going to have a defensive posture, or a prediction that you're going to fall, or just a prediction that your self-motion priors are very imprecise. So that's the second element, really. And then I suppose as more imbalanced symptoms, as more errors are fed up through here, that feeds back and reinforces a metacognitive belief, and therefore keeps this perpetuated. Moving on to motor behaviors, the idea, we're trying to simplify things to three types of motion. So one is voluntary action reduces, and that's as people become less able to, or perceive they're less able to do it. And so I suppose, rehab strategies might try and increase that and have modest success. I think with this, if the precision of self-motion priors is very low, this might lead to lesser sensory attenuation, which feeds into, again, higher precision-weighted prediction errors there's less suppression of your input on account of your motion because the motion is not treated as very precise. And then metacognitive beliefs of imbalance could lead to defensive actions, so very stiff postures, which again it starts to train the wrong motions and sort of reduce this familiarity with ordinary motion. And then we get this other phenomenon where there could be corrective actions, such as a very low threshold of sway for stepping or correcting your action, where a certain amount of the same amount of objective error leads to much more easily triggering a corrective response on account of its higher precision. But all of these leading to dysfunctional motor patterns, which themselves then help perpetuate this state of sort of failure to optimize your priors and the precision of your prediction errors. I think that was just a little summary of everything we've gone over here. And then there's this additional element that doesn't seem to be there in every case, but it receives a lot of emphasis in some cases and models, this sort of reliance on visual input, and then the very strong symptoms experienced with moving patterns, things that overwhelm or compromise visual input or obstruction of. And so I think the idea being that actually this could become recruited because the prediction errors from vestibular cortex are not trusted as a source of, or not proving themselves as a source of updating your self-motion priors. So if they become an unreliable source of feedback, then it will become natural to see what other areas can be a more reliable source of feedback. And I suppose, and this can, what will then end up happening is I think you'll reach a local minimum on free energy, because as you bring this in the shorter term, you are able to come up with better self-motion priors and monitor the predictions they generate more accurately. But what it's doing is that it's actually preventing the vestibular channels that should be the mainstay of your self-motion priors from assuming that role. And so it's actually just further exacerbating the problem on a wider scale or a longer term. And then, of course, if this is interrupted or there's a sudden visual event, you may have sort of temporarily lowered your baseline or your ongoing prediction errors, but then individual events that interrupt this might lead to very large brief surges of prediction errors on your sort of self-motion priors. And then we come into the precipitants for how you get here. And I think there's a common element that there's very likely to be a kind of an unexpected elevation in your bottom-up vestibular prediction errors. And this could come from an insult to the subcortical pathway, or even the peripheral, subcortical or peripheral vestibular neuronitis, stroke, you name it. It could come from a fall or an external event that makes you stop trusting your, that increases your vigilance, or there could be another factor that just, such as a heightened state of anxiety, where you're in a more generalized state of monitoring, but again, it would feed into this excessive attention here. So it can come lower down in the pathway, or maybe if you've not got this optional precipitant, maybe one of the factors we've just gone through kicks it off, potentially increased vigilance or attention or anxiety acting at the level of vestibular cortex. And I suppose thinking about the optional insults, if you do have an insult, then not trusting having these sort of high amplitude prediction errors that aren't accurate or very good at updating your priors, and therefore constraining your range of motion, believing yourself to be unsteady and paying a lot of attention, are adaptive. And I think we have to explain 3PD as something that is rooted in adaptive processes to the circumstances. And the key thing that goes wrong is that this sort of, one or more of these four add-on processes doesn't deactivate itself appropriately and keeps this perceived state of balanced threat going even once the original threat has subsided. So I think, I think we've said all this. So putting it all together, this is just how it looks all on one page. Again, you have this core of the feedback loop between your self-motion priors and vestibular motion inference that is subject to high levels of ongoing error and fails to correct itself. And this can be perpetuated by attention, metacognitive beliefs, defensive motor or altered motor behaviors, or visual reliance, all of which sabotage and prevent otherwise normal self-optimization here. That's obviously already too complicated to be particularly useful to patients or clinicians, but we might be able to simplify this at the expense of losing a little bit of accuracy, saying that, at the core of this, what we perceive is all the motion or signals we didn't expect times the attention we paid, and that what feeds into this are our beliefs, because that influences what we expect and the attention we paid, the visual input, how much we monitor our movements, and the ways we actually move. And obviously our beliefs will directly influence movement behaviors. Just a few things to say about a number of the associated factors. Depression or anxiety, we've heard about the role of SSRIs, and depression or anxiety are associated with deficits in serotonergic processing. These could, so anxiety, could cause hypervigilance or influence metacognitive beliefs. There may be a more specific role of serotonin I might come on to in a minute. Sympathetic arousal, so noradrenaline, cortisol, again, modulators of sensory responses and vigilance and gating could be very key. If you look in the migraine literature, which is related, although different, one of the consistent findings that's reported between episodes in people with migraine is this enhanced intensity dependence of auditory evoked potentials, and there's a similar thing in visual evoked potentials, which is kind of characterized by a failure to habituate to repetitive stimulation by appropriately decreasing or attenuating responses. And this is linked to many affective disorders. And it could well be that if there's a serotonergic deficit here, then actually failure to habituate to frequent or repetitive vestibular signals could be part of what gives you these sort of persistently elevated error signals reaching vestibular cortex, or at the level of vestibular cortex. Intolerance of uncertainty is a cross-cutting transdiagnostic trait that's associated with a number of mental health condition risks, particularly anxiety disorder, but many others. And I think it's interesting to think, given that uncertainty is defined as expected surprise, which relates to the precision of priors, it could be that sort of the formation under conditions of high uncertainty, the formation of overly precise priors, even if they're inaccurate, might reduce the amount of uncertainty experienced, even if it's inaccurate with respect to the events that are going to unfold. So this could be another mediator between some associated conditions. And I suppose just to say that there's an overlap between this sort of pure 3PD that is people are vulnerable to all ages, and then there's been work that a number of my colleagues on this have done with older adults with perceived imbalance, where there actually may be a lot more wear and tear or degradation of some of the peripheral or central pathways. And I suppose there may be a continuum. So we sort of said that this kind of state could be entirely adaptive when the system is sufficiently compromised, and it just reflects that. It could be entirely maladaptive if the system is undamaged, and it could be somewhere in between. And I think we've talked about functional neurological disorder, how at the heart of that, mechanistically, there's said to be maladaptive and overly precise priors. And that could fit with this model in two ways. You could have maladaptive and overly precise priors of self-motion directly, or you could have a one level higher maladaptive, overly precise metacognitive prior of imbalance that keeps the precision or sort of erroneously constrains your self-motion priors at the next level down. So just thinking about some potential biomarkers or testable hypotheses coming, I've hung them on the simplified model just because there's no room on the full one. But just how we might in individual cases expose different components. So looking at gait analysis could help you look at actual movement patterns. That's relatively accessible. Beliefs, I think there's a lot of paradigms. There's these false estimation, comparing the sub-paradigms. We've heard already about comparing subjective and objective, and then these broken escalator paradigms where people can be sort of oversensitive to anticipated movements that don't happen, or sort of slow to update and relearn new situations. Visual inputs, you can look at vestibular-visual conflict paradigms, or things like we've heard about. And again, movement monitoring. We could look at, we've just heard about alpha suppression as an objective correlate of movement vigilance, and it could be we could find ways to contrast subjective or objective measures of prediction errors. And I think if we correctly compare differences between active and passive motion, or attended versus unattended high threat, low threat situations, we've heard about a lot of this. And then I suppose finally, what we'd hope to work towards is sort of this core part that however you get there, in the right settings, you should see elevated objective prediction error signals, at least to self-generated vestibular signals. And I think the appropriate paradigms such as vestibular evoked potentials or mismatch negativity that allow you to distinguish between predictable and unpredictable stimuli might provide the granularity to kind of really take a hypothesis-driven approach to what these brain areas are doing, rather than a more blanket, untargeted, well, let's scan the brain and see what's different approach that's been done so far. So that's as much as I'd prepared. We've gone a little bit over. Thanks everyone for your attention. I suppose that, well, as I had a few questions of my own, but maybe I should that we're still grappling with a bit, but maybe we should have more of an interest in the audience's questions.
Thank you, Will, and thank you to all our speakers. So let's each of us unmute and give them a round of applause. Thank you everyone for the fantastic talk. Now we open the floor to our audience to ask questions and have an ensuing discussion. Are there any questions from our audience? If not, maybe I can venture one. This is certainly not my area of expertise. So I will just be asking a low-level logistical question: is what do you plan? What's the next step for the paper? I suppose this is going to be a model paper and with hopefully validated model paper. So is this the next step that you're going to take? Just publish the paper, or is there anything also after that?
I think that's the aim, is to start with the theoretical model paper, and then yes, as Will has sort of outlined, there's then testable hypotheses as a result of that. But the immediate thing is to just publish a sort of theoretical paper.
Are there any other questions from the audience?
More of a comment. I think that your articulation of this is very, very clear, and I tried to put a little model together, and it looked more like a really ugly cartoon. So I really like how precisely you put all of this together. I think the question, and it's a question I've had the longer I've spent some time trying to understand active inference, is what's appealing to it is that there is this hierarchical model that ultimately manifests in one's metacognitive perceptions of what's going on. And I wonder how much, because what we do therapeutically is we attempt to affect those metacognitive beliefs because they seem to be, very tangible targets for us as interventionists to be able to somewhat speak into those. And I wonder how much does that permeate? I've spent a lot of time in the past trying to help someone's illness perceptions and so forth. And the feedback I started to ponder was, well, am I implying that they're just thinking about this incorrectly? And if they could just think about this correctly, then everything is going to get better. I know that's a part of it. So I just wonder how much of that does ultimately permeate into those lower systems that I think mechanistically we feel more confident are at play. So I don't know what the answer to that is, but I this is something that I've been pondering, quite a bit. And to what extent to summarize my question, to what extent do the metacognitive beliefs permeate into what's happening mechanistically? Should I be focused more on just, hey, let's move, and the extent to which I can convince you to move is probably where the clinical dialogue needs to focus.
Perhaps if I take that, and then Will might add bits onto my answer maybe. But I think what we're saying is that these are not necessarily in discrete processes, that they are that yes, there is these loops that are different, but there is overlap between all of those kind of feedback loops as well. And so when we put it within a traditional kind of intervention like CBT type of modality, what you would say is that actually all of these things in terms of like how we think about things and how we behave are actually all related. So if you have a beneficial effect on one, you're likely to see beneficial effects on the others. And yes, you're right, in terms of intervention, it's often a difficult place to start thinking about adapting cognition, where perhaps an easier place to start is through behavior. But what you'll often see then is, as a result of that, then cognitions change. So I guess this is also sort of one of the questions that I had in terms of, well, if you're looking at what we term as metacognition may not necessarily be the accurate term here, but those kind of beliefs or cognitions about the illness, it may be this sort of very top-down driven thing, but it's likely to be interfering at maybe different levels of that hierarchical model as well. I don't know, Will, whether you had anything else to add to that.
Yeah, thank you. No, it's a great question. So I suppose, returning to the question, hypothetically speaking, if you could tell someone and they would absolutely believe you full as possible, just move and you'll be fine, would that be enough? If you go Dumbo's magic feather, as I suspect the experience is probably, no matter how compelling and you know, charismatically in everything you do, it probably doesn't work particularly well just taking that approach. And I suppose I'd maybe frame it in terms of necessitate of what do you do to foster a corrective experience. And I think what's happening is people are experiencing a whole succession of I'm struggling for the converse term to a corrective experience, but they're constantly having experiences that reinforce the need for their maladaptive strategies. And what you want to do, I suppose, is, and I think that's because I suppose they're using there must be some heuristics people are using each time they move to judge, did that go well, how well or badly did that go? And therefore, you know, and if it continues to go badly, they continue to try and compensate. So I think there might be, and I'm, you know, I am speculating here, and I don't have an extensive experience working with this patient group specifically, but I think what we'd want to work towards is a corrective experience each time they move, ideally, or each little bunch of times to move. So, which would agree on identifying what's the outcome measure that individual is using to assess, did the movement go better or worse than expected? And I suppose it could be directly the sense of imbalance, which is the final result, or it could be if you can agree these are the strategies you're using, you know, that one of the things is you're using corrective stepping more, or requiring more vigilance or something. So I suppose if you could then agree a sort of not full movements, but a reduced or simplified set of movements within a safe space you can do that makes them come out going, oh yeah, I had less use of that corrective strategy, or I required less of this, or I experienced a bit less error, then I suppose it's working from that through a series of corrective experiences would be how I would envisage it. But I'll stop there and not speculate too much, because I don't have the sufficient experience to back this up.
No, I think actually, Will, I was going to add to that, because I think that's a very good description of in vivo exposure, actually. So what we would, and the way that sort of I formulated our approach to triple PD at the moment, which we're doing a trial in, is, well, actually, it came out of a clinical observation that a patient with triple PD was, one of their main problems was on stairs, and so we took them on stairs and just showed me how to do it, and they were eliciting a lot of sort of safety behaviors or doing that. And actually, by the end of the session, because we got him to run up and down the stairs and he didn't fall, that sort of error, that, you know, so-called prediction error, although I know, you know, more in terms of learning theory now, but was enough to change his belief so substantially that actually eliminated the threat that he perceived in relation to those symptoms, that he could still do these things without falling over or having the catastrophe. And that's what we tend to find with the rehabilitation, is the symptoms only tend to subside completely once you've eliminated that threat, that cognition relating to threat. How you go about that, of course, is always or can be quite tricky.
All right. Maybe I would venture a question on the acute improvement of symptoms. I know you said something, David, about using SSRIs and SNRIs, but what about more GABAergic focused medications like benzodiazepines? Do they improve the symptoms on the acute administration? Because they seem to me, at least theoretically, speculating that they would lower the precision of those faulty maladaptive priors.
I don't prescribe medication. Diego, do you want to take that? I'm not a medication expert.
Benzodiazepines are pretty non-specifically useful in dizziness. They're used a lot in other countries for acute dizzy episodes. So people that have acute vertigo, for example, in the States or Spain or other places, they'll often be given benzodiazepines as an acute treatment. But actually, in chronic syndromes like this, that's not actually that helpful, because a lot of what it's doing is just masking the problem. Actually, it's not achieving long-term resolution of the problem and not altering beliefs, which is, I think, ultimately what we're saying is critical here. So although yes, I mean, they're also addictive, and there are lots of other problems with benzodiazepines, but we don't tend to use them routinely in this setting. And I think it's sort of it's an easy way out, often in the acute setting in A&E, to get them back home, but actually probably not the best long-term approach.
See, yeah, right. Good. All right. So, if there are no other questions from the audience,
Do you mind if I just follow up? Because
just Mark, go ahead. Sure.
I really appreciated your example about the stairs. I think that's what I was trying to get at, is when you take someone to the area where, you know, they're having low perceptions of self-efficacy, and if they can succeed in that repetitive process. I don't know if that's really exposure or habituation. I guess it is in some sense, but really what it is experiencing some success where they previously had a lower perception of success. And it seems like when they do that, they can arrive in their success, then the illness perceptions follow. You know, so I guess what I'm getting at is, to what extent do we need to address illness perceptions in a sort of declarative standpoint, except to where it can convince someone that it's safe enough to try, and then the therapy is very active in that way. And then I know that's what your paper is getting at, is that your therapy is very active, but I'm just wondering, you know, how quickly can I, as a therapist, cut to the chase to try to get to that self-efficacious moment, and do the illness perceptions then follow, and in a sense the affect may follow from that positive, you know, you could say rewarding experience. So are the illness perceptions and the emotions kind of like the readout? And if we can get at that self-efficacy rather quickly, will that, you know, that's almost like I don't know if that's a bottom-up experience, but it's kind of an in to out when I picture different perceptions of illness and ultimately perceptions of self, perceptions of ability. If we can get to those, do those others follow?
Yeah, I think that's a relevant question, and I think that any such model, such as the one that we're proposing, would allow or elicit multiple avenues of where one could intervene. And actually, if you do intervene in one area, then we should see beneficial effects, you know, in those other areas. So yes, exactly where you then target your intervention may differ, but yeah, there should be multiple ways in to intervene, essentially, is what we're trying to say, I think.
Right. Well, thank you all for your questions, and I think now it's Carl's turn, if I'm not mistaken.
Good. Is it my turn now?
Seems so, Carl.
Lovely. Okay, that was a wonderful conversation, and it's particularly nice that Mark could attend. We had quite an in-depth discussion of application of active inference and the like to vestibular function a few weeks ago. So, Robert, it might be worthwhile, when we're sending around the recording of this session, to also provide a link to a session which I think Christoph chaired, and that was on the 7th of January by Mark Broberg. And I won't rehearse what we went through there, because the team here, I think, are fully versed in the you know, what we rehearsed at that time. But I think there may be some useful points and sort of points of contact between Mark's work and perspective and this particular PPPD issue, which was absolutely fascinating. I don't think I'm going to be able to nuance very much what you've already discussed. You clearly are completely on top of this on a number of from nearly every perspective that matters, even to the extent that I imagine you've already got a 12,000, if not 18,000 word of paper to cover all these points, which so in that spirit, I'm going to try and summarize some of the key themes in the fond hope that it will allow you to either in different avenues or indeed in terms of the white paper, sort of winnow it down to what really matters and keep it simple. And I'm very mindful of Will's notion that it has to be sufficiently simple that you can explain it to your patient or client in 2 or 3 minutes, and it clicks and they get it. And that's often quite a challenge when you're trying to accommodate everything and put the science-based approach behind it and motivate things for clinicians. So I'm going to just revisit some of the foundations of the framework in the fond hope of being able to join the dots in a simple way that the story follows naturally and is easy to explain to somebody without compromising on any of the sort of architectural or conceptual details. But I just did want to pick up on a couple of sort of key issues that came out in the discussion, and in no particular order. This last notion in the discussion of illness perception and remediation or therapeutic intervention. And it did strike me that's quite an important point in the sense that applying, and I think it was David who mentioned this, but certainly taking the philosophy of CBT to the next level and using the patient's own body and lived experience as scientific evidence for her that there might be another way of thinking about this consciously. So sort of leveraging Mark's observation that if you get this right, the different ways of thinking about this volitionally or propositionally will be an emergent property of something more fundamental. But that can be realized by basically allowing the subject to gather evidence from her own body that this hypothesis that has been discussed in narrative form in the outpatients is apt to explain her sensations and her approaches. So I think that's a really nice way of sort of bringing together an insight, a mechanistic insight into the subpersonal neuromodulatory mechanisms and the etiology of those and the self-maintaining factor with the perceptual aspect, that you can actually induce a program of scientific exploration in the therapy, very much again like what I remember of CBT, say hyperventilation, for example, actually getting the subject to hyperventilate in front of you and is talking through why these sensations are emerging from a sort of physicochemical or sort of biophysical perspective. So I thought that was worth emphasizing. I also mentioned the notion of sort of self-maintaining behaviors right from the illness perception through to the failures of neuromodulation or gating. And that's a theme that Will has emphasized in many instances, particularly in relation to things like tinnitus, for example. I think that's another important theme which should be foregrounded in the paper. That and one way that I look at this is that there are certain modes of operation in any predictive processing scheme or sense-making scheme that can sometimes be in one of a number of stable states. So, and usually what one finds is there's the normal way, and there's a pathophysiological sort of attractor or state of being, and sometimes you get kicked out and then you revert, but sometimes you stay in there. I'm mindful of that nice diagram where you have the divergence of people recover or they don't, and that suggests to me that there's sort of a bistable aspect to, from a technical perspective, the free energy minima that covers everything from Bayesian beliefs about this, the way that my body works, right through to the precision assigned to various prediction errors in the body. And if that's the case, then the explanation for why some people go on to develop these chronic conditions, I think, can be, gracefully and usefully addressed from that perspective. Why is it that you get stuck in this attractor? And that means that there should be some degree of local optimality, like a local minima in sort of optimization to this. And one thing which Will has often emphasized is it's sometimes easy to get stuck in these pernicious states of sense making and decision making and predictive processing if that very state in and of itself precludes any opportunity to gather evidence that you could be in another state. So it's self-maintaining in the sense that you just don't go and gather any evidence that means you might be wrong, and this is not necessarily the optimum state to be in. So the classic example would be, say, agoraphobia, social withdrawal, or accompanied by sort of depressive or with anxious symptoms. That because you are socially withdrawn, you never go out and gather any evidence that it's actually okay to engage in interpersonal dyadic interactions. And I'm just wondering if in a sense, I got that sense that Will was telling that same story here, that there is a certain parasitic but also autopoetic aspect to the chronic condition, in the sense that the patient denies herself the opportunity to go and gather evidence. In fact, she can do this, and she doesn't need the vestibular input. And that example, that in vivo therapy, actually, accompanying the subject walking up the stairs, that provides exactly the kind of evidence that otherwise, without any therapeutic intervention, would not be available, and thereby be again, autopoetic or self-maintaining, simply because of the nature of the active inference or the evidence gathering and the sense making available to the subject. So I thought that was an important theme. I think slightly separate from the underlying sort of narrative of why I'm feeling like this and why this is happening to me. There were a number of other themes. Well, perhaps before we, no. If you'll now indulge me, I've just got a couple of papers that might be useful if you read the abstracts, and if anything engaged you to go into the details more deeply. That might be useful to substantiate some of the points, particularly in relation to the experimental paradigms and the neuropharmacology that might be, they're not going to speak directly to your model, but they will provide examples of this kind of a model and how it can be leveraged empirically and in terms of therapeutics in related fields. So if I can grab the screen, what I'll do is I'll just quickly go through those and hope that they remind me what to. So what we're going to do is to share the screen down and go for this one here. Right, why have I put this one up? I put this one up because this is the sort of the genesis of or the formal description of the starting point of the three pillars of the model. And I should say at start, Will, you sort of intimated that this is a minimal model and it's a bit over-engineered because it has at least 4 parts, and you actually mentioned as a sort of tetrapartite approach. To my mind, I think you can make it a little bit simpler if you just say, if this happens, then this must follow, then this must follow, and then this must follow. So I don't think you need to actually say there are 4 pillars upon which this model rests. I think there's just one pillar and everything else follows from that. And that one pillar, as you're intimating, is a failure of the attention of vestibular precision. And everything else will follow from that. And I'm going to use that phrase a lot because, specifically a failure of sensory attenuation a lot, because I think that that is a really useful notion when you're trying to describe to people why they have this odd ability to ignore certain cues, and why the loss of that ability to ignore can be very distressing and explain a lot of the symptomatology. And the second reason I put this paper up is, again, something that Will and, well, two people mentioned, which was paradigms that evince sensory attenuation and its failures, and in particular sort of force matching paradigms. So on a number of occasions people talked about sort of hypervigilance, perceived stability, and specifically perceived intensity. And what this paper does is it goes through, just from first principles, looking at the fundamental importance of sensory attenuation from a mathematical perspective, but then simulates the force matching paradigm that highlights some of the sometimes counterintuitive effects. Is there anything useful here? Yeah, effects that could ensue if there were to be a failure of sensory attenuation. And indeed, this work was actually aimed at empirical work using the force matching illusion in people with schizophrenia done at the Institute of Psychiatry to explain why people with failures of sensory attenuation have a peculiar and particular and unique resistance to the force matching illusion, and how that then can be quite a sensitive empirical measure for assessing people's ability to engage sensory attenuation. Perhaps, well, now let me just complete this and I can get rid of this and before rehearsing what this formulation of sensory attenuation implies. What that would speak to is, for example, that lovely slowly rotating chair paradigm, comparing the subjective assessments when the rotation was other caused versus self-caused. So if there was any way of pressing a button or causing where the subject was in charge of inducing the rotational movement, possibly subliminal or threshold, and then compare their subjective ratings under the conditions of self-generated movement versus non-self or other generated movement, that will be the acid test. And what you're looking for is no difference in the patients, which is the signature of the failure of the sensory attenuation. It gets conceptually quite tricky, and I always sort of trip up on myself when trying to interpret this, but basically what you're expecting to see, that in normal people who can engage sensory attenuation, because they're attenuating the sensory evidence, reporting the intensity of a particular could be vestibular, it could be auditory or visual stimulus or event, then when they are now reproducing that in the absence of any sensory attenuation, and they match the same causes of that input, then they always overestimate, so that they, in the context of the force matching illusion, you always think that somebody punched you harder than you punched them, effectively, and that difference depends upon the sensory attenuation, such that if that attenuation fails, you would expect no difference. So you have this interesting inversion of the hypervigilance of a patient actually experiencing these symptoms whilst acting and whilst moving, compared to when they are reporting the intensity of their sensations by calibrating some externally or other produced sensations in the absence of action. So it is an interesting sort of game to play, just to how you interpret these paradigms. But the bottom line is, in terms of developing a metric or an empirical biomarker or electrophysiological or possibly fMRI phenotype, or indeed sort of psychophysical phenotyping of the degree of impairment of sensory attenuation, It, it it may be that the paradigms you're using could be crossed with other versus self emotion in order to measure the difference. If you can do that, then you've got the opportunity now to cross that with a pharmacological intervention and ask the question, do GABAergic interventions work? Do serotonergic interventions work? Should I try adrenergic pharmacology? Because then you've got an empirical handle on the specific deficit, and you can sort of answer questions. No, in fact, benzos are too non-specific. But in fact, actually, the cholinergic seems to work just as well as the SSRI, the serotonin reuptake inhibitors. But to be able to say that, one would clearly need to have a well-validated, probably either psychophysic or psychometric and hopefully electrophysiological bedside kind of paradigm that you could use to start to address some of these questions. So I thought that might be a useful example, not so much the theory, although it is terribly interesting, but really the demonstration of the theory in a practical context with the force matching paradigm. So how do we get rid of this one? I see. We'll come back to that in a second. Another paper that sort of tackles this in a way which is more directly relevant to, I think, your setting, but not speaking to vestibular, the integration of vestibular and proprioceptive and somatosensory and exoreceptive visual information is this paper. But this paper does, by Jakob Liwinowski, look at the integration of proprioceptive and visual input, and in particular using things, a development or an extension of the rubber hand illusion and ownership and the like, and asking very specifically, how can one understand and empirically estimate the attention paid, either increasing the precision or the sensory attenuation, namely attenuating or decreasing the precision of various inputs that are modality specific. And specifically, this would speak to, for example, the increased reliance upon visual inputs relative to proprioceptive input as you get older. Simply because the visual input remains more precise than the sort of the proprioceptive input, particularly from your feet when you get to my age. But this was addressed empirically using quite an elegant paradigm, in the sense that it used a haptic glove, which afforded very precise timing. And psychophysics that then were, if you like, underwritten by neurophysiology using brain imaging, I hope. Oh, perhaps not. Perhaps this was a simulation. Anyway, this may be just a useful example of the kind of experiments that one could do that speak to quantitatively estimating the precision afforded different modalities and different modalities under action versus passive viewing or passive movement paradigms. So this chap has written quite extensively about this from both a very pragmatic neurophysiological perspective, but also from a philosophical perspective, in terms of what it means to be aware of one's body and oneself. And casting it purely in terms of this remarkable ability to control or act upon your own information processing through setting the precision of various prediction errors at different levels in a cortical and subcortical hierarchy in a context-sensitive way. So I thought that might be useful, and that one can go away. This paper I've just put up as a very broad brushstroke treatment of which neuromodulatory neurotransmitter system you would pick if you wanted to identify candidate pharmacological interventions on a purely theoretical basis. And it's a little bit abstract, and just to cut a long story short, when you're talking about the precision or the encoding of precision, which is the encoding of inverse uncertainty in the brain, then you are basically talking about how you apply gain control to various sources of information, which in predictive coding are usually prediction errors on the newsworthy, unpredicted part of the primary sensory afferents, or anything higher in the hierarchy, and that involves a modulation of postsynaptic gain of those populations, or possibly even specific cells, reporting the, let's say, prediction errors as the newsworthy information to the next level. And at the next level, there are also mechanics that effectively install predictions about trajectories and dynamics, motor trajectories, for example, in terms of recurrent connections and message passing on neural processing, recurrent processing at any given level. And interestingly, it seems that the precision of the neuronal message passing from one level to the next level seems to depend on acetylcholine or cholinergic neurotransmission, whereas the dynamics and the trajectories within any one level may depend more on adrenergic gain control mechanisms. Both can be read in terms of different kinds of exogenous and endogenous attention from a psychological perspective, but they do have an interesting dissociation, which means that, I noticed somebody talk about cholinergic neurotransmission as a potential target for this. And that would certainly make a lot of sense if this is a failure of sensory attenuation, because we are talking about the ability of low levels of systems in the extended vestibular-ocular system to pass the right kinds of messages that may or may not be attenuated depending upon action. So we're talking about that's what Will meant by the likelihood mapping. He just meant the sort of what's the likelihood of these prediction errors given my beliefs at a higher level, and that is encoded in these forward ascending projections whose sensitivity or gain corresponds, or selective gain corresponds to the precision that you have in a top-down way, instantiated through this kind of mental action, according to Jakob Lemninsky. So this just provides some evidence for why you might be looking at cholinergic as opposed to serotonergic neuromodulation. It also, in fact, not this paper, but another little paper. What's it? Oh, that, no, we've done that one. Okay, excellent. I'll just use this paper just to highlight why you might also expect there to be some effect from GABAergic and other drugs that affect inhibitory interneurons, just because of the neuronal circuits that may mediate sensory attenuation right in the periphery. In this example, it's right in the spinal cord, where we're associating gamma motor neurons with with this encoding of precision that set the gain via interactions with fast spiking inhibitory interneurons. So there's one would expect certainly a non-specific, possibly transient therapeutic effect of GABAergic or anything that had a sort of anesthetic effect, but it would be, as been pointed out, very non-specific. What I want to say, want to show. So this paper comes from Rick Adams and Stuart Shipp. Rick pursued this and is pursuing this kind of inquiry in schizophrenia research. Stuart Shipp is an academic, but very expert in the anatomy of many different systems. Has written a lot about the neuroanatomy, the microcircuitry of predictive coding, right down to the synaptic detail. But what I wanted just to focus on was just to rehearse for those people who don't know this story, the sensory attenuation story, how simple it is, and just pick up on the the three subsequent elaborations that constitute the four pillars. This is not necessarily the best graphic, but if we just focus on this picture here, where we're casting motor control or behavior as basically the fulfillment of proprioceptive predictions by classical reflex arcs. So here we're down in the spinal cord. We're receiving some set point or some predicted proprioceptive top descending proprioceptive prediction. It is compared with the primary sensory afferents from, say, muscle spindles or stretch receptors. The ensuing prediction error is then just returned to the neuromuscular junctions until the prediction error is cancelled. So this would be the equilibrium point hypothesis of motor control. And on this view, basically the brain, the central nervous system, is basically providing predictions of what I expect to feel, and then you offload all the actual heavy lifting in terms of moving in a way that it was intended to the peripheral reflexes, so that they just fulfill the predictions by eliminating the prediction errors. So on this view, the CNS and the extended motor or indeed vestibular system here can be seen just in the job of predicting what it's going to feel next and see next. But the feeling, the proprioceptive predictions are actually fulfilled by by classical reflex arcs. And you can extend this to interoception and autonomic reflexes if you want, but at the moment we'll just stick with this sort of proprioceptive motor control picture. So your prior beliefs now become intentions, and your intention is then broadcast as a descending prediction of what you would expect all the consequences of your intended movement to be. Those predictions that are supplied to either motor or autonomic reflexes can then be fulfilled, and in so doing, they actually change your postural stance or your motor plant in a way that then produces the predicted visual inputs. And you can now think of the descending predictions as sort of motor commands and corollary discharge, but they're just predictions of what I'm proprioceptively going to feel and what I am visually going to feel in terms of what I'm visually palpating, which should, in the normal run of things, all be internally consistent. But notice in doing this, what we're doing is we're taking these low-level sensory prediction errors and diverting them back to the world or the body in this instance. And we are effectively attenuating the ascending prediction errors that get up and drive belief updating in your extended cortical and subcortical hierarchy. So that's what's meant by sensory attenuation. It's the ability to temporarily stop your intended movements. Sorry, it's your ability to suspend any messages or information or evidence that your intended movements are not actually being fulfilled. Because if you don't attenuate the ascending prediction errors, then these are going to go up and update your beliefs. And immediately, subpersonally or possibly personally, your beliefs now, Bayesian beliefs, will be, oh, I'm not moving. I intended to move, but in fact, if I just pay attention to or allow the evidence for the movement to ascend the hierarchy, then all the evidence says, oh, I'm not moving. And that basically subverts or eliminates the prediction error. So there's no prediction error now to drive the reflex. So the simplest example of this would be Parkinson's disease. That, if I have lost the ability to attenuate ascending predictions through transiently reducing the gain of the ascending prediction errors or cells of origin of the ascending prediction errors, then as soon as I have an intention to move, it's immediately subverted by all the evidence at a very low level, some spinal and very low level. It's immediately subverted. Oh, I'm not moving. So quite naturally, you won't move. This is a very simple explanation for sort of bradykinesia, and one could argue sort of psychomotor poverty. It's completely base optimal. You're just overly sensitive to the fact you haven't started moving yet. So you subvert your attentions if you can't suspend this the precision, or you can't attenuate temporarily during the initiation of a movement the evidence that you're not moving. And of course, once you've moved, then you can now you suspend your sensory attenuation, and then you attend to what you're actually, say, looking at, or what you're actually palpating, and then that attention now allows you to do your belief updating, and then you decide your next move, and off you go again in the saccadic system, where the sensory attenuation will be saccadic suppression, namely you can't see visual motion during the actual placement of your eyes in the right place. You get the saltatory act, sensory attenuate, act, suspend the sensory attenuation, attend, belief update, act again, and you do that every 250 milliseconds for saccadic eye movements. So this, so if there was a failure of the sensory attenuation, what would happen? Well, it would mean that first of all, you wouldn't be able to realize with precision intended movements. So it would look as if you were extremely hesitant, or just looking a very small distance into the future, taking one tiny step at a time, simply because you can't get in the flow such that your motion is basically being realized. All your predictions are coming true in a fluent and in a future pointing way. But if you're subverting your predictions, then you can't do that. So you become very hesitant, very slow, very bradykinetic. What will that look like? Well, that has to be predicted by your higher levels. Now you have to find an explanation. Why am I not moving properly? Oh, I'm broken, or I'm very hesitant, or and so on, until it may reach a narrative or propositional level that could be articulated in terms of self-modeling, and indeed verbal reporting to oneself, or indeed the clinician, and then you get illness perception. So that emerges from this primary problem, which would be the failure of sensory attenuation, and that's what I was trying to hint at in terms of each of the four levels really follows quite naturally from the first, and then you just left with the story. Well, how did it all start? Well, it could all start in well, perhaps we should just speak again to the self-maintenance, because of course, if you've now now trying to make sense of a failure of self-attenuation such that you are very hesitant, you're not moving, how are you going to compensate? Well, you may well start to compensate for the overly precise vestibular information by increasing the precision of your visual information. And in so doing, you look as if you are attending much more to the visual information, or you could start to learn that you've lost the ability to attenuate, and you're not the kind of thing that moves fluently, and that's completely base optimal. And and that would lead you into this self-sustaining, rather pernicious local minima, sometimes called parasitic attractor in the schizophrenia literature in the old days, which you've now completely properly inferred that you've lost the ability to attenuate this vestibular input, and therefore you are now somebody who suffers from PPPD. And everything makes entire sense, and you're always, and then you can start to ask. So that would be the sort of self-maintenance. The genesis of this, I thought was interesting. Sort of people brought to the table neuritis as one form of a failure to attenuate. I usually appeal to Weber's law, that sort of where imprecision really corresponds to sort of signal to noise. But I'm sure you're much more fluent than I am in thinking about the original etiology, but whatever, because you've now got a you now have to tell a story in terms of the failure of sensory attenuation at a very low peripheral level that is in the context of hierarchical processing. You can't divorce the hierarchical context from the initial insult. So the initial insult could indeed be at a high level. And I say that because mathematically, it's just the relative precision at each and every level that matters. So you'll get exactly the same Bayesian belief updating or predictive coding or neural message passing self-organization if you either increased the sensory precision or decreased the prior precision. Mathematically, there's no difference. The actual drives, if you like, mathematically depend just upon the ratio. And that gives you a notion now as to why people's illness perception could be almost regarded as a delusion. It's a very precise belief that is now brought to the table to match the precision, the unattenuated precision of all the sensory evidence, just to regain that balance, and they become committed to being a person with PPD and behaving in exactly the way that they believe people with PPPD behave. So that might be another avenue, just to sort of again, get this holistic notion in play. It can't be any other way once you subscribe or commit to this kind of story. So
Carl, can I interrupt and just ask a quick question about that sensory attenuation? It's something I've been curious about for a while. Is that sensory attenuation under normal circumstances complete, or is there any gradient there? So in other words, a partial attenuation.
Yeah, first of all, it's not complete in the sense that it's very selective. It's just whether you direct it upwards or downwards. So it's really like a tap or a switch. You can either, I think of it in terms of, I can either cause the movement by attenuating the ascending prediction errors, or I can prevent the movement by subverting or switching the prediction errors so they go up. So there is no complete attenuation. It's got to get, the prediction errors have to go somewhere. The free energy has to go somewhere. It's either does it cause you to move or does it cause you to change your mind?
Thank you.
Yeah, I think you're asking a more subtle question, but so it's often in other contexts. So this kind of failure of sense attenuation is used to explain hallucinosis. As basically a failure to do proper attribution of agency because of unattenuated self-produced sensations. Now, if that were true, that would mean I can't hear myself speak. But clearly I can hear myself speak. So, but not in the way that it is so potent it revises my beliefs about how I'm going to talk. And the motor programs and the motor proprioceptive predictions that underwrite the actual action. So it's not complete in that sense. Obviously, I can hear the sounds that I make. However, if I now delay the auditory consequences of my speech, so I actually sort of record what I'm saying and play it back, say 200 milliseconds later, that'll stop me speaking. Because I can't now I've broken my partial attenuation. It's I've now if you like destroyed my ability to attenuate. So when I was expecting to have attenuation in play, sorry, when I was expecting to attend, so it's now your turn to speak, as it were. I'm still hearing me, and that can that will basically preclude you from talking. And some people think that's the explanation for stammering, for example. But that example suggests that no, the sensory attenuation is never complete, but it's certainly contextualized in the right kind of way that it doesn't undermine your intentions or the flow with which you're passing through these various sensory motor states that are themselves contextualized by higher representations and predictions. I imagine that with suitable paradigms, you can actually quantify the degree of the partial sensory attenuation. I'm not aware that has been done. But I'm sure it's not a switch like on and off, but much more subtle than that. Where are we now? So, this is an interesting example, and I brought this one up when people would, when you were showing those interesting results about the alpha rebound and alpha suppression. I would be interested to ask, but don't waste time by indulging me whether it was sort of high or low alpha. In the motor system, there is quite compelling evidence that the amount of induced beta reflects, or the beta suppression reflects this ratio. So in a simple-minded story, beta suppression during movement just is your sensory attenuation of your sensory precision, and there's some lovely connections between the gain of particular components of neural circuits and the frequencies with which they resonate, and this makes a lot of sense in terms of the underlying neurophysiology. And then you get a beta rebound, which would be like having moved, looking at what the consequences of my movement and selecting the data. What I'm showing this paper for is that if you wanted to mention your alpha rhythm fluctuations and differences between people with and without PPPD, then this would be a little. This would substantiate your arguments in the sense that there is a similar story relating to beta activity as the correlate, as the neurophysiological biomarker of sensory attenuation, or the attenuation of sensory precision in the motor system. And what you predict is that people with Parkinson's disease would fail to show this kind of beta modulation because they've lost the ability to modulate the sensory precision of the proprioceptive system. And just interestingly, while I'm on this, of course, the motor system is usually the precision of the motor prediction error formulation, message passing in the motor system is usually associated not with serotonin or acetylcholine, but with dopamine. And before I forget, serotonin usually is associated with interoceptive prediction errors, which makes a lot of sense in terms of highlighting the functional anatomy in terms of the posterior and anterior cingulate. Insula. So I think you've got a good story to tell for nearly all classical neuromodulatory systems and attendant drugs there from one point of view or another, but perhaps less for the dopamine in terms of well, I don't know, perhaps not. So where are we? Yeah. So this was work by James Kilner, but pursued empirically by Claire Palmer, which might be interesting just to refer to and to read. That's not should be there. This is there's one missing, which is a shame. Never mind. Perhaps this reference in this. This, for those people, most of you will know this, but this is my review of these kinds of ideas as they play out in psychiatry. But there are a few references to neurology, which may or may not be interesting, and pain perception, for example. So I just highlight this as a potential review. One of the interesting things in this review is the final common pathway of inhibitory interneurons in mediating precision and the electrophysiological correlates that involve fast spiking inhibitory interneurons and characteristic changes in the spectral frequency of EEG fluctuations or induced responses. Just to say, most people think that gamma reports the ascending prediction errors, whereas beta and alpha is more a report of the descending predictions. But what we don't know is whether they're predictions of content or predictions of the precision. But there's some interesting stories to tell. My apologies. I was hoping to find some work by that had Mark Edwards looking at the force matching illusion empirically. I think with Claire Palmer, but I can't. But no, Parisi. But I won't waste your time any more. But there was an interesting body of work pursuant to that formulation of the force matching illusion, done with James Kilner and Mark Edwards using EEG, where they may have used the kind of paradigm that you might want to use in terms of looking at the differences between self-generated and other generated movement, specifically in terms of sensory attenuation, Parisi. Perhaps Robert, I'll email you the link just to include with the links to the recordings that ties together that sort of Mark Edwards functional neurological symptom perspective on precision control in a hierarchical context with the more mechanistic, electrophysiologically grounded measurements of sensory attenuation that we've been talking about, which may or may not have something that's interesting. Good, that's all I have to say. Thank you very much.
All right, so we will have another round of applause for our speakers and for Carl, as usual. And with this being said, I think, Carl, you can stop the recording. And Carl, if you're just so inclined, will you stay 5 more minutes with me at the end after people leave? I have something to ask you, if it's possible. Thank you. So thank you all for joining, and we will make this recording available publicly after the publication, but we will circulate certain